All right, so we're good. Let me get my FA and we move on. All right, so we're going to continue the immunology from where we stopped the last time, and let's see how far we can run with it. So we're able to do the complement system the last time. So now let us do the cytokines. Now, you cannot do immunology without understanding cytokines. If you don't understand cytokine, you've not done immunology. I like understanding things from the basics. When you understand things from the basics, it will be a lot more easy for you to relate with those things. Now, the word cytokines are very big. What is this word cytokine? Like, what is the meaning of the word cytokine? Now, what you need to understand is this: cytokines are various substances that are secreted by your immune cells to bring about a particular response. That is what you need to know. Now, let me just use the normal human body as example. You are a doctor, you have patients that come to your hospital with different diseases. Now you have a lot of medications you can use to bring about different biological responses in your patient. For example, if a patient comes to your hospital with very high blood pressure, that is hypertensive emergency, you definitely go to the pharmacy and pick up a medication like your nitropuroside, your labetalol, your hydralazine, your phenodopam. Now, those medications are chemical substances that are specific for bringing down the blood pressure. If somebody come with very high amount of glucose, like somebody with HHS or somebody with diabetic ketoacidosis, you go and you bring insulin and you give to the person. The blood sugar comes down. Now you see that there are different chemical substances you give in different disease condition to achieve a particular desired result. That is the same thing that happens in the immune system. Your immune cells are capable of producing specific chemical substances that will bring about a particular immune response that the body needs at that point in time. Now, those chemical substances are what you call the cytokines. So each cytokine has a function they are supposed to mediate. So if the immune cell wants to bring about, let me say, neutrophil chemotaxis, they want to recruit neutrophil, they will produce interleukin 8. Interleukin 8 will definitely go and recruit neutrophil, and the function is settled. Now, there's a way I like to look at cytokines, and that is how it is easy for me. You're free to adopt that method, or you're free to develop your own method. If your own method is easy, we can even adopt your own. Now, I like looking at cytokines the same way FA looks at cytokine. You look at it based on the cells that produces them. Now, there are two broad cells that produces cytokines. We'll still narrow them as we proceed. Now, those cells are your macrophages and your T cells. But in the T cells, we will narrow them into your Th1 cells and your Th2 cells as we proceed. So this is how we're going to look at the macrophage. This is how we're going to look at the cytokines rather. The first group will be the ones that are produced by your macrophages. That's how we're going to start. Now, see, in this business, It is important to know the things that are important. And it is also important not to bother about things that are less important. If you major on the minor and minor on the major, you will have problem at the end of the day. So my responsibility is to tell you the things that are important and the direction you should look at these things. If you look at it in that way, your problem is solved. Now, the macrophages produces basically 5 cytokines. Now, there's a group of cytokines we call the acute inflammatory cytokines. So they are called acute inflammatory cytokines. These are 3 basic cytokines: IL-1, IL-6, and TNF alpha. Now, why are these guys called acute phase or acute inflammatory cytokines? Now, these particular cytokines are capable of mediating fever and acute inflammation. 3 of them. That is the first thing you have to know. And 3 of them are produced by macrophages. So let's start with IL-1. Now, you see, in this pathway, IL-1, that is interleukin-1, has 2 functions you have to know. For those of you who have been privileged to do some of the MBMEs, you will see them press this function of IL-1 very commonly. Now, IL-1 is an acute inflammatory cytokine, so it will cause fever. IL-1 will definitely go to the hypothalamus and cause your cyclooxygenase enzyme to produce prostaglandin. Now, the prostaglandin that is produced by your cyclooxygenase enzyme will automatically raise the thermoregulatory set point in the brain. And of course, fever will definitely happen. Straight up, like there's no 2 ways about it. Now, if that is understood, we'll definitely move on. When we move on, the other thing IL-1 is known for is the fact that IL-1 definitely cause activation of osteoclasts. So it is called the osteoclastic activating factor. And this is the one that is very important in this pathway. Osteoclastic activating factor. Now, see the challenge. When you look at your bone definitely has 2 different processes that goes on. It definitely have the build-up process that is mediated by the osteoblasts, and it definitely have the breakdown process that is mediated by your osteoclast. Now, IL-1 activates the osteoclast and favors bone breakdown. So if you see somebody that has a bone pathology and they are asking you which of the cytokine is implicated in this patient disease, it's going to be IL-1. If you've done MBME, that is a very lovely question that MBME enjoys a whole lot. So these are the 2 things you should tie down to interleukin-1. Interleukin-1 can do some other things. It can definitely increase expression of addition molecules in the endothelia. That one is not important. If you go and know that one, and you don't know that it is osteoclastic activating factor, you don't know that because it's an osteoclastic activating factor, it can cause bone pathology. You have not known IL-1. Because you'll be so surprised, you go to your U-ward, there'll be nothing like IL-1 and endothelial addition factor. You go to your MBME, you will not see anything like that, but they will keep pressing you on the osteoclastic activating effects. So those are the 2 things you should marry with IL-1. Now, when we talk about IL-6, IL-6 has 2 important things in this pathway that are very, very important. Now, the first thing about IL-6 is that it is an acute inflammatory cytokine. So it's going to mediate fever, first of all. Now, aside fever, It does something that is also very, very important. Now, see, whenever there is inflammation, there'll be what we call acute phase reactants being produced. Now, what are these acute phase reactants? For example, the lack of your fibrinogen, the lack of your transferrin, the lack of your hepcidin, the lack of your C-reactive protein, the lack of your amyloid A protein, all these are acute reactant proteins that, that you see during inflammation. Now, those proteins are produced at the level of the liver, but the liver cannot just produce those proteins except it is signaled by interleukin 6. So IL-6 is the one responsible for acute inflammatory protein production. That is what IL-6 does. Now let's look at, those are the two important functions of IL-6. Now let's look at your TNF alpha. This is the third of the acute inflammatory cytokines. Now your TNF alpha is the most important cytokine so far of all the cytokines, whether produced from macrophages or whether produced from T cells. Your TNF alpha is super important. If you haven't known TNF alpha, you have not known any cytokine straight up. Now, see what your TNF alpha does. First of all, TNF alpha is going to mediate fever because of its position as acute phase inflammatory cytokine. Now, aside mediating fever, it is going to cause endothelial leak. That is, it's going to cause blood and fluid to leak away from the blood vessels. If blood and fluid leaks away from the blood vessels, automatically that is going to reduce the intravascular volume. And once the intravascular volume is reduced, you're going to get hypotension. So your TNF alpha is the one responsible for causing septic shock. Now, one of the characteristics of somebody that has shock is that you must have hypotension. So if people have infection, that infection is definitely going to mediate a high amount of TNF alpha to be produced. Once TNF alpha is produced, fever comes because of its role as an acute inflammatory cytokine. Then it causes that endothelial leak. Once the endothelial leak happens, this person in question automatically will definitely have septic shock because the blood pressure drops straight up. So your TNF alpha is very notorious for doing that. Now, the TNF alpha is responsible for maintaining granuloma. I'm going to talk about this when I talk about interferon gamma. I will bring about All right, so I'm sorry. The Wi-Fi I'm using is connected to the electricity directly. So there's a power outage. So it definitely had to restart. All right, so I'll have to unmute you just 1 second so that somebody can quickly tell me what was heard very clearly, the last thing that was heard very clearly. Please, just one person so that we'll move on. So what did the house hear very clearly?
TNF alpha
All
maintains
right, thank you.
granuloma.
So let's keep moving. So TNF alpha maintains granuloma. I'm going to talk about that when I talk about the interferon gamma, basically. So not now. The final thing TNF alpha does is this. It is responsible for causing cachexia. Cachexia is extreme weight loss in certain conditions like malignancy. You've seen people that have malignancy, you see that they lose a lot of weight and they are very, very thin. It is definitely interferon gamma that does that. Now, we have settled the acute inflammatory cytokines that the macrophages produces. Now, there are two more cytokines that are left. That is IL-8 and IL-12 that the macrophages produces. They produce 5 cytokines. Now, your IL-8 has just one function you have to know. IL-8 is responsible for neutrophil chemotaxis. Now, if an inflammation is going on somewhere, your neutrophils are basically inside of the blood vessels. Now, if an inflammation is happening, let me say at the level of the knee, neutrophils will have to leave the blood vessels and go to the knee to sort out that inflammation. How will neutrophil be able to know that that inflammation is happening at the level of the knee? That is, of course, where the like of your interleukin 8 comes in. They are the ones that direct the neutrophil to the site of inflammation. So that is why they are called the neutrophil chemostatic factors. That is the only job it does. Now, IL-12. Now, what you need to understand is this. IL-12 is produced by macrophages, but IL-12 is responsible for causing stimulation of cell-mediated immune response. Now, see, when I told you about your helper T cells, I told you that your helper T cells are a wonderful group of cells in the sense that anything you want, the helper T cell can make it happen. It is that kind of guy, just telling what you want, anything at all, it will definitely bring it to pass. That is just the job of the helper T cell. Now, when you want a cell-mediated immune response, the helper T cell will have to differentiate into the Th1 cells because it's the Th1 cells that can drive the cell-mediated immune response. It is your interleukin 12 that we have to push your helper T cell to go to that Th1 type of cell. I will definitely bring about the interplay between macrophages and T cells, and it will make sense. So the interleukin 12, it comes from the macrophages. It causes your T cell to move into the Th1 cells. Once it moves into the Th1 cells, it will activate natural killer cells, macrophages, and you will have a cell-mediated immune response. That is what your IL-12 does. Now let's switch this thing and move over to look at the interleukins that are secreted by your T cells. Now, when we look at interleukins that are secreted by your T cells, we look at it in this category. Let's look at the ones that is secreted by your T cells generally. Now, this one is T cells generally. So is coming from just T cells. There is no specific. Now, there are now other ones that come from specific T cells. For example, there are other ones that we come from the helper T cell 1, and there are other ones that we come from the helper T cell 2. These are basically the way we're going to look at this. So let us start by looking at the ones that come from the T cells generally. Now, when we look at the ones that come from the T cells generally, that's where we look at two of the cytokines. That's where we talk about the IL-2 and we talk about the IL-3, basically. Now, the IL-2 is responsible for the growth and proliferation of every type of T cell. So IL-2 and 3 come from general T cells. Now, the IL-2, what IL-2 does is this. It promotes the growth of all T cells. So it increases the growth of everything that is called T cell, whether it is cytotoxic T cell, whether it is your helper T cell, whether it is your regulatory T cell, as long as you're a T cell, the job of IL-2 is to definitely stimulate your growth and proliferation straight up. Now, when you look at your IL-3, IL-3 is also produced by general T cells, but IL-3 serves like a growth factor for bone marrow stem cells. That is what it does. It helps the stem cells that are responsible for generating of blood cells to grow and proliferate. Basically, the job of IL-2 is very important because IL-2 is used by oncologists to treat a lot of cancers because it is your cytotoxic T cells that fights against cancers. IL-2 also causes the growth of natural killer cells too. It is your cytotoxic T cells and natural killer cells that fights against cancer. So if I definitely produce a medication that can enhance the effect of IL-2, it will definitely suppress tumor growth when we go to oncology to become a very important medication. Now, if this is settled, we have looked at the cytokines produced by the T cells generally. Now, let us look at the ones that are produced by your helper T cell type 1. Now, when we look at the ones that are produced by your helper T cell type 1, that is where we look at the interferon gamma. Now, when we talk about the interferon gamma, we'll go and have some conversations relating macrophages and T cells together. Now, see, your helper T cell 1 produces just one cytokine, which is your interferon gamma. Now, what does your interferon gamma do? Interferon gamma, okay, let me take it from this so that it will make sense. Let me draw the macrophage T cell circle and let me also draw the granuloma pathway. Let's start it at this point. Now, this is the macrophages, this one here in black. This is your T cell in red, the normal T cell. Now, see what happened. Macrophages will definitely pick up maybe an organism or so, and the macrophages will become activated. When macrophages are activated, they will produce interleukin 12. Remember, IL-12 is produced from macrophages. Now, this IL-12, their job is to come to your T cells. These are the T cells. These are macrophages. Now, when this IL-12 come to the T cell, remember what it do. It will cause this T cell to differentiate into the helper T cell type 1. This is now the helper T cell type 1. Now, once you have gotten the helper T cell type 1, the helper T cell type 1 will now produce interferon gamma. Now, this interferon gamma we now come and stimulate macrophages. Now, when it stimulates macrophages, it will cause these macrophages now to kill these bacteria it has engulfed that started the whole pathway already. That bacteria will die off. Then it will also stimulate macrophages to release TNF alpha. This is how your interferon causes an interplay between macrophages and your T cell. So if you look at the functions of your interferon gamma, it will help in granuloma formation. It will definitely help to stimulate macrophages to kill the microorganism they have phagocytized. Those are the important functions. Basically, those are the very important functions. Now, the lack of iso switching is not very important. Avoid it at this point. Now, if this thing is a bacteria that cannot be killed, a granuloma will need to be formed. The body understands what it can do and what it cannot do. The body knows its limits. It does not want to overdo. Now, the body weighs every microorganism that comes in. The body weighs it appropriately. Will I be able to remove this or will I not be able to? If the body can kill it, it will go ahead and kill it. If the body knows it cannot kill it, it has to ward it off in a granuloma. Granuloma means I am protected against the organism. The organism is also protected from my immune cells. It's a 50-50 association. Now, see the way granuloma form. Granuloma also form from this same pathway. The organism stimulates macrophage. Macrophage release IL-12. IL-12 stimulates your T cell to go to your helper T cell type 1. Helper T cell type 1 produces interferon gamma. Interferon gamma will stimulate macrophages to produce TNF alpha. TNF alpha will now cause aggregation of macrophages to form the epithelial giant cells that gives you the granuloma. Now, in summary, interferon gamma and IL-12 are responsible for granuloma formation, while your TNF alpha is responsible for maintenance of that granuloma. That you need to know. So these are the functions of interferon gamma, and I have played it in different pathways. These are the things that are important, even though it's not in the literature like this, but this is what you keep seeing in the MBMEs and the UWorld and everywhere you look. Now, if you look at your Th2 cells, that is the helper T cell type 2. These are the ones that mediate humoral immune response, that is antibody mediated immune response. This is where you have your IL-4. This is where you have your IL-5. This is definitely where you have your IL-10. And this is where you have your IL-13. Basically. Now, when you look at IL-4, before we go to IL-4, let me take you back the memory lane a little bit. I think that should be our first or second discussion. I told you something that immunoglobulins are produced defaultly as immunoglobulin M. Now, it is only when there is a signal that something that we call class switching will happen, where the immunoglobulin type will move from the IgM to either IgG or IgA or IgE, depending on what the body needs at that point in time. Now, the signal for that switching are the cytokines. Just think about this thing. If you're driving your car, for example, if you're driving your car will continue to move in that lane you position it. Whether there is an obstacle in front of you or not, it will continue to go in that lane. The car can only change course if you definitely produce a stimulus by turning the steering. That is the only way the car can change. If not, even though there is a trailer in front, the car is moving towards the trailer. It's not his business. That is the same way the immune system works. In the immune system, the default immunoglobulin is IgM. Whether the bacteria or the viruses that is around needs IgG or IgA is not the business of the immune system. It will continue to give you IgM except it gets a signal that tells it, stop producing IgM, switch it from IgM to IgA. It will not switch it. Those signals come from your cytokines that are produced by your helper T cell type 2. Now, your IL-4 is responsible for class switching IgM to IgG and IgE. That's the most important thing you should know. So IL-4 class switches IgM to IgG and IgE. Basically. Now, IL-5, on the other hand, does two things that are important. IL-5 helps class switching from IgM to IgA. And then it also helps eosinophils to grow. Remember, I told you eosinophils are the ones that definitely helps in the handling of parasites. So that is what your IL-5 do. It moves IgM to IgA. It also causes your eosinophil to proliferate. Now, your interleukin-10 is simple. Interleukin-10 turns down the cell-mediated immune system. That is what it does. It reduces the cell-mediated immune response. That is just the job. That is the reason why, if you think about it, your regulatory T cells turns off the immune system via IL-10 and transforming growth factor beta. Your IL-13 is not so important. That one produces IgE, basically. So I have been able to tie in the various cytokines and their importance in the pathway, the things you have to know. I have sorted it out the way you should appreciate it. Now, let us move on. Now, this is the respiratory boss. This is a very important pathway. I just have to laugh because there's just a lot in this respiratory boss. Now, when you look at the chronic granulomatous disease, this is the foundation of the chronic granulomatous disease. If you miss it out at this point, you will definitely miss out the entire chronic granulomatous disease. Now, see what you need to understand. When your macrophages or your neutrophil engulf a bacteria, have you ever asked yourself, how do they kill this bacteria they engulf? They kill these bacteria they engulf via production of toxic substances. That is where the respiratory burst comes in. So the respiratory burst is that your macrophages, your neutrophils are capable of producing deadly substances, which are in turn capable of destroying the bacteria that are engulfed by these microorganisms. Now, let us play with these concepts a little more. Look at what happened in the macrophages. This is what happened in the macrophages. Now, when a macrophage captures a bacteria, the macrophage will use normal oxygen that is readily available in the cells. So this is normal oxygen. it will pick this normal oxygen and convert this normal oxygen into oxygen radical via an enzyme that is called the NADPH oxidase. This is the enzyme that does this job, NADPH oxidase. Now, the NADPH oxidase requires NADPH as a cofactor. It requires NADPH as a cofactor. For those of you that read biochemistry with me sometime in February, if I'm not mistaken, you definitely know that we settled it that the NADPH comes from the hexose monophosphate chain. Now, you see, this oxygen radical is no longer oxygen. No. This one is deadly. Now, the other thing that will happen is this. This oxygen radical will move to hydrogen peroxide. That is the next lethal substance that is produced. And this hydrogen peroxide is produced from oxygen radical via the enzyme superoxide desmutase. I will abbreviate it as SOD. And finally, your myeloperoxidase will come in and move this hydrogen peroxide into hypochloric acid. So this is your myeloperoxidase. Straight up. Now, your oxygen radical, hydrogen peroxide, and hypochloric acid, three of them are lethal substances. Three of them have the capability of definitely destroying those bacteria that the neutrophils or macrophages has engulfed. That is how neutrophils and macrophages are able to break down the bacteria they engulf. But now look at where the whole thing gets important. This is where it is super important for the pathway. There are some people that are born with a deficiency of the NADPH oxidase. Those are people that have the chronic granulomatous disease. Now, see, those people don't have this particular enzyme. If these people don't have this enzyme, what it simply means is that this entire pathway cannot form from this point to this point, cannot form. Because if you don't form oxygen radical, there's no way you're going to form hydrogen peroxide. There's no way you're going to form the hypochloric acid. There's just no way you're going to form any of it at all. So if there's no way you're going to form any of it, it simply means that there's trouble. But don't panic. There's a solution. Now look at the solution. Bacteria also produces hydrogen peroxide. Normal bacteria produces hydrogen peroxide. So what the neutrophil will do is this. The neutrophil understands I cannot generate my own hydrogen peroxide. So let me capture this bacteria. When I capture this bacteria, I will steal his own hydrogen peroxide and I will use it and destroy it. So that is what the neutrophil does, and everybody is good. There's no problem. But as time went on, some of the bacteria noticed it that something is not right. Some human beings don't have NADPH oxidase. They depend on our own hydrogen peroxide to destroy us. If we can take away our hydrogen peroxide, we'll render them helpless. Those bacteria now develop what we call catalase. That was where the problem started. Now they develop what they call catalase. Now see what catalase does. Catalase breaks down this hydrogen peroxide and take it away. So the bacteria actually produce hydrogen peroxide, but before the neutrophil will lay hands on the hydrogen peroxide, catalase will break it to water and oxygen. So in that condition, the neutrophil is helpless because one, it cannot produce its own. The one he was hoping on stealing from the bacteria is now wise enough, breaking it down. So people that have this condition are susceptible to having infection by only one group of organisms, that is the catalase positive organism. But the catalase negative organism, they can handle them because those organisms does not produce catalase, so they cannot break down their hydrogen peroxide. Neutrophil will steal it. But you see, any organism that is catalase positive that have the catalase enzyme becomes a problem because they cannot handle it. And that is why the name of that disease is called chronic granulomatous disease. Whenever the body sees something it cannot handle, it forms a granuloma to ward it off. That is the best it can do. That's why you have chronic granuloma in that disease condition. That is the most important aspect of your respiratory boss. Now, let's look at this thing in another phase. The body produces hydrogen peroxide regularly in your blood cells and in a lot of other places. Now, the question is, how are you going to handle this hydrogen peroxide that is being produced? Because if the hydrogen peroxide is allowed to accumulate, it's going to cause a lot of problem. When you produce it, you have to break it down after use. Now, see, this is how hydrogen peroxide is handled in the body. The first thing is that you will need to produce your NADPH because NADPH is going to be important in handling this hydrogen peroxide. NADPH is produced from your hexose monophosphate pathway, where glucose 6 phosphate, I'll call this G6P. This is glucose 6 phosphate. We go into phosphogluconolactone. So I'll call this PGL. This one will definitely give you NADPH. This is where NADPH is produced. It's going to use NADP as a cofactor and give you NADPH. Now, that is the first thing that needs to be done. Now, there's a particular enzyme that is called the glutathione peroxidase. Now, the glutathione peroxidase, this particular enzyme here, glutathione, let's call it GLUT-P. So this is glutathione peroxidase. This is the enzyme that is responsible for converting hydrogen peroxide into water and oxygen. You can see it's balanced. The equation is balanced. But now the challenge is this. This glutathione peroxidase requires reduced form of glutathione as a cofactor. So it requires reduced, let's say this is reduced glutathione as a cofactor. And at the end of the day, it will give you oxidized glutathione. See, for those people who did biochemistry with me in February, I was able to tell you that without a cofactor, a chemical reaction can never take place. For example, think about it. You're in Houston, Texas. I like using Houston for this example. And you have a job interview in Dallas. Dallas is still in Texas. And you just bought a new car. Let's say you bought a Mercedes Benz, brand new. And that Mercedes Benz uses gas. It is not an electric car. It uses petrol. Now, that car is brand new. Everything is functional. But I kid you not, if you don't have petrol in that car will never take you to Dallas. It's not that the car is faulty. It's because there's no petrol. That is a classic explanation of enzyme and cofactor. The cofactor is like the petrol or the gas. The enzyme is like the car. Now, the glutathione peroxidase is working very well, but if there is no reduced form of glutathione, the enzyme cannot work. And that is where your NADPH comes in. This your NADPH now, what it does is that it converts this oxidized form of glutathione to the reduced glutathione. Once you have the reduced glutathione, the reduced glutathione will activate the glutathione peroxidase. It will break down hydrogen peroxide into water, and everybody is good. This is the major problem in G6PD deficiency. That one is going to be settled in hematology. That is all what they were trying to talk about here. We definitely broke it into two halves. We talked about the ones that happen in the bacteria, and we also talked about when the body is trying to resolve hydrogen peroxide. Those ones we settled. So we have definitely settled all of this. Now, when they say the likes of Staphylococcus aureus, Aspergillus, these are catalase positive organisms. I've already settled it. By the time you read through, it will definitely be easier. What we do is definitely pick up the concept and explain it to you without just reading the textbook word for word. You have the book, you can go and read it. But what we have done is that we have broken down the concept in such a way that everybody can understand. Even though this is your first exposure to immunology, you can appreciate the concept we're trying to push forward. Now, if you look at the interferons, look at their name, interferons, they interfere with something. Now, these ones are responsible for interfering with DNAs and RNAs. You see, the way this pathway is, knowledge are progressive. For those people that did molecular biochemistry with me, it was unfortunate we didn't record that. But for people that did molecular biochemistry with me, at this point in time, you will definitely be picking up a whole lot of things we're tying in at this point in time. You will definitely be the one picking so much. Because when you look at the molecular biochemistry we talked about, you will discover that your cancer cells are rapidly dividing cells, and every rapidly dividing cells will definitely require large production of DNAs, because without DNAs you cannot replicate, you cannot divide. And that is where your interferons become important. Interferons can interfere with those DNAs and RNAs, so automatically you can use them against tumors. Kaposi sarcoma is a tumor. Hairy cell leukemia is a tumor. Condylomata acuminata is a benign tumor. Renal cell carcinoma is a malignant tumor. Melanoma is malignant. Now, what it does here is that it just truncates the DNA. It interferes with the DNA production. So it shuts down the proliferation of all those malignancies straight up. That is what it does. Now, another thing you need to know too is your viruses exist as either DNAs or they exist as RNAs. So if your interferons are capable of interfering with RNAs or DNAs, it also makes sense that they will definitely be able to shut down the replication of viruses. That's why I use them to treat the likes of hepatitis B virus, basically. Now, if that is settled, let us look at the surface markers. Now, there are certain things you will see, and you should be able to tell that this thing I'm seeing is a T cell, is a B cell. There are different types of T cells. Which of the T cells are you seeing? Is it a helper T cell? Is it a cytotoxic T cell? Now, the first principle I want to establish is this. Your CD, your CD markers are definitely used in picking out your different cells. You would have definitely heard of CD3, CD4, and the rest, basically. Now, what I need you to understand is this. You can have higher number of the CDs and you can have lower numbers of the CDs. First thing first, what is this CD4 you talk about? It is funny that a lot of people don't even know the meaning of the CDs. It is cluster of differentiation. First thing first, CD means clusters of differentiation. Now, see what Look at the example I want to give. If somebody from the America call you, if you see a number from America, you know that this is a number from America. Straight up, you know that this call is coming from America because it's going to start with +1, especially if you're not in America. Like if I'm in Ghana and somebody from America is calling me, it's going to show +1. If me, a Nigerian, is calling you, it's going to show +234. If you look at it, you will say, oh, this call is definitely coming from Nigeria. How did you know? You just look at the dialing code. That code was specific for a particular country or region. That is how the cluster of differentiation works. The cluster of differentiation is a tag to particular immune cells, such a way that when you see it, you know that, oh, this one is definitely a T cell. Oh, this one is definitely a natural killer cell. Oh, this one is a macrophages, because they have specific tags to them. The same way countries have specific dialing code. Two countries cannot share the same dialing code. Even though you have boundaries with a particular country, your code will be different. Mexico and the US shares boundary, but they have different dialing codes. Now, if that is settled, let us now move on. The next thing I want to tie in is that the CD numbers that are less than 10, CD numbers less than 10 are more for T cells. CD numbers that are greater than 10 are more for your B cells. This is the second thing you need to add to your knowledge bank. Then we can continue playing with the concepts. You need to get to a point where you play around your concepts. You just you're studying, you're trying to marry them around. That is the only way it makes a lot of sense. Now, let's look at your T cells. See, there are different type of T cells, but for me to say this thing is T cell, you must have 3 receptors. Now, the marker of T cell is CD3. CD4 is not a marker of T cell. CD8 is not a marker of T cell. Those ones tell you the specific type of T cell. But when you want to determine, is this thing a T cell, what you're checking for is CD3. Anything that has CD3 is a T cell. You can now move forward to know what type of T cell is that. So all your T cell must have the CD3. They must have the T cell receptor. This is the one that helps them to interact with either your MHC1 or MHC2. Now, apart from having the T cell receptor, they must also have the CD28, because when they interact with the MHC receptor, if it is a normal body antigen that is presented to them, they are not permitted to be activated. But what of if it is a foreign antigen? Remember the co-stimulatory response I taught you in the last class. The co-stimulatory response will be activated, and you need the CD28 for that. So these 3 receptors must be seen in every T cell. Now, this is where we now move into the different type of T cells. This is where we now move to look at the different type of T cells. Now, if this thing is a CD4 type of T cell, if this is a CD4 type of T cell, now, in addition to these 3 receptors, you must have these 3 constant. So in addition to these 3 receptors, you will now have your CD4. This is what makes it the helper T cell. Now, aside the CD4, you will now have the CD40 ligand. This is the one that helps it to class switch your B cell. So CD40 ligand, you see it in the helper T cell. And then one of the things you have to know is that they are going to have the CXCR4 receptor, I will explain, and your CCR5. These are receptors for HIV. So I'll just call this helper T cell. HTC. So your HTC, we have the three receptors above. That denotes is a T cell. In addition, it's going to have CD4. That makes it the helper T cell. Of course, helper T cell will have the CD4 T ligand because it will be responsible for class switching of your B cells. Now, it will have your CXCR4 and your CCR5. Those are receptors specific for HIV. If somebody has HIV infection, you're checking for CD4 counts because that is the cell HIV affects, and it affects it via these receptors. Now, if you're dealing with a cytotoxic T cell, it is going to have the three receptors above that we confirm is a cytotoxic T cell. That is a T cell first. That's these three receptors. Now, what now confirms is a cytotoxic T cell is the CD8. Wherever you see CD3, it is a T cell. You will now start asking yourself, what are the other receptors? Those are the things that we now push it to the specific. So this one is the cytotoxic T cell. Now, when you look at your regulatory T cell is a type of helper T cell. So it's going to have the three receptors above. It's going to have CD4 because it's a variant of helper T cell. But what we now make it the regulatory T cell is that it's going to have the FOXP3. And it is also going to have the CD25. Once you see this, you settle it classically. This is definitely your regulatory T cells. No two ways about it. Now, this is your T cells settled. Now, remember the things I told you. If you see your B cells have CD receptors that are usually above 10. So CD19, CD20, CD21, we can have the conversation at the level of the literature now because we've tied the difficult ones. So your B cells will have the CD19, CD20, CD21. CD21 is a receptor for Epstein-Barr virus. Now, all your antigen presenting cells, we have your MHC class 2 and your B7. Macrophages is an antigen presenting cell. Check, it has it. B cells are antigen presenting cells. Check, they have it. MHC class 2 and B7. Because the MHC class 2 is what is going to present the antigen to the T cells. Then the B7 is what is going to bind to the CD28 to definitely cause the co-stimulatory response. Now, when you talk about your natural killer cells, the natural killer cells, the major surface marker that will tell you that this is a natural killer cell is definitely your CD56. That is the important one. CD16 can be seen in other cells, but once you see CD56, it is specific for NK cells. Don't confuse that with CD55 or CD55 is the DAF, the one that protects us against complements. Now, when you talk about your macrophages, first thing first, macrophage is an antigen presenting cell. So you will see MHC class 2. You will also see B7 on their surface first. Now, the specific marker for your macrophages is your CD14, straight up. CD14, that is the straight up marker for them. Now, funny enough, macrophages has the CCR5. A lot of people don't know that HIV affects your CD4 cells, but HIV are also capable of affecting macrophages. Reason being that macrophages has the CCR5 receptors, which your HIV can also pass and get into the macrophages. Now, the final ones are your hematopoietic stem cell that are CD34. Now, have you ever asked yourself, How is it possible that when they are doing bone marrow transplant, they just know for sure that this particular one in question is a stem cell? Because when you're doing bone marrow transplant, what you're trying to transplant is a stem cell. That is the specific things you want to transplant. If you transplant any other thing, there will be problem. So my question to you is, how do you think these doctors know that this one they have picked up is a stem cell? That is where the surface marker comes in. That is why I told you surface marker is very important. Just like somebody calling you from Nigeria, you see that code, you know that, man, this call is definitely coming from Nigeria. So all they do is they just check for the CD34. Once they see a CD34 marker on the surface of that hematologic cell, it is definitely a hematologic stem cell. They harvest it and they transplant it. Straight up. Now, let's look at the energy. Energy means T cell exhaustion. Now, it is not every antigen you present to a T cell that will cause that T cell to be activated. No, that is not how it works. There are certain antigen you will present to a T cell, and instead of the T cell to become activated, they will even become exhausted. Straight up. They will become exhausted immediately. Now, that is where we look at the concept of the energy. That's where that concept of energy comes in. Now, when we talk of energy, energy means that you presented a self antigen to the T cells. Now, when you presented a self antigen to the T cells, automatically the T cells recognizes it as self. Once it is recognized as self, it will stop to function. Because if it becomes activated, there will be problem. So that period where it becomes exhausted and ceases to function is what we call the energy. Straight up. Now let's look at the concept of passive and active immunity. In the first class, I tried to explain these concepts. I differentiated the innate, adaptive, and the passive immunity. I gave an overview of that. Now, in a layman's term, if you want to look at passive and active immunity, think of two different types of people. Two of them are definitely millionaires in dollars. Two of them are living good lives. But one of them works hard for his or her money. That one was born into a family that has nothing. He works for every single dollar bill he has. And the other one has never worked for all his life. He inherited a fortune from the parents. And he's definitely spending as much as the person that has worked all his life. Now, that guy that inherited that fortune from his family is likened to passive immunity. The guy that worked every single of his dollar bill is likened to the active immunity. In passive immunity, you don't work for it. Somebody has worked for it and you just inherited it. For example, a child that is in the womb, the mother passes IgG to the child. The child did not work for it. The mother worked for it and gave it to the child. The same thing for a child that is breastfeeding. The mother passes you IgA. You didn't work for it. The same thing for people that they give immunoglobulin, already formed immunoglobulin. For example, if you get pricked by a hepatitis B infected patient's needle, they will give you the hepatitis B immunoglobulin, which is an already formed antibody against hepatitis B, especially when you're not immunized. That thing was formed by somebody else, or it was formed by another process, and it was given to you. You didn't form it, but you've inherited it. Those are passive immunity. Now, the active immunity is the one you have to work for it. They will either give you vaccine When they give you vaccine, your own immune cells will not be stimulated. Vaccine is not immunoglobulin. No. Vaccine is like a weakened form of the organism or a killed form of the organism. When your body sees that weakened form of the organism or the killed form, it will definitely trigger production of immunoglobulin. That is, you work for it. Another way you can also develop this is that you got the infection actively. For example, most children in America, they are immunized against chickenpox and measles by receiving vaccination. Children in Africa get their own immunity by getting the disease itself. Of course, measles and chickenpox is not something that is serious and it's not something that should be taken as life-threatening in Africa. It's something that is common. You would have definitely had friends once or twice that had chickenpox in the course of their life. It's not something that's it's not something people even ends up in the hospital in this part of the world. Now, those children, after they have gotten that chickenpox, of course, they definitely get immunity against varicella. These are definitely the active form of immunity. Now, if that is understood, let us look at certain conditions where you have to combine active and passive form. A classic example is somebody that has needle prick by a patient infected with hepatitis B, especially if that person is not immunized. Now, what you will need to do is immediately that person was pricked, you have to give the person hepatitis B immunoglobulin. That is a passive form of immunity. And you quickly have to sustain that with a hepatitis B vaccine. Now, you can see that you're doing the two type of immunization concurrently, the passive and the active type. Now, if that is settled, we'll definitely have to move on. Now, when we move on, we're going to look at the vaccines. Vaccines are very simple. They are very easy. There are things you can definitely play around with. There are things you can play around with. Now, there are different types of vaccines. We're going to talk about the ones I think that are important to the pathway. The mRNA vaccine, which is the COVID vaccine, is a controversial vaccine. And I don't want to go into the controversies concerning the mRNA vaccine, but if you understand, if you have certain understanding about that mRNA vaccine now, you would understand where certain doctors are coming from when they are saying the things they are saying, and it's making sense to a lot of people now. That is why they definitely withdrew the COVID vaccine as being mandatory for travel and the rest. Now you can travel around the world without your COVID card. Nobody wants to see it again. Unlike before, where you cannot get into certain countries except you show them evidence that you're fully vaccinated for COVID, or they're going to quarantine you for like 2 weeks before you get into their country. So the mRNA vaccine is not an important vaccine for this pathway because of the controversies that surrounds it. When they clear the controversies, probably the USMLE can now consider it very serious. Now, let's look at the life attenuated vaccine. Let's start from that. Now, the life attenuated vaccine is that you bring that organism and you render it harmless, but it is alive. Now, think about a dog. If you look at a dog is able to cause problems with his teeth and his claws. Those are the two things a dog can use to fight and to attack and to do the things it can do. You watch all these guys that test the strength of a dog bite. Now, imagine you bring that dog and you pull out all the teeth of the dog. The dog doesn't have teeth anymore. All the claws of the dogs too was cut out. That dog appears as a normal dog. It can be very scary looking at it, but that dog is harmless at that point in time. You can put your hands in the mouth of that dog. It cannot bite you because it doesn't have a teeth at that point in time. That is how the life attenuated vaccines are. The organism, they bring it and they render it non-pathologic, like it cannot attack anymore. And they now inject it into the individual. Now, if you want to show a child a dog and how to run away from the dog, you have rendered the dog harmless. You can just release the dog for the child, and the child will definitely run towards the escape path. And you teach the child, if the dog is coming next time, run through like this. That is what the vaccine does. Now, they bring that non-pathologic organism. When the immune cell sees it, they respond as if it is pathologic. And by responding, they definitely produce immunoglobulins. And immunoglobulins will definitely have the memory B cells that will continue to produce them in future. Now, you see, the life attenuated vaccine is a very strong vaccine, but it has certain important things you have to know. Now, there are about 4 important things you have to know in life attenuated vaccine. First is never give life attenuated vaccine in people that have primary immunodeficiency syndrome. Now, there are 2 types of immunodeficiency syndrome. There's the primary and the secondary, or primary and acquired. For example, HIV is not a primary immunodeficiency syndrome. HIV is acquired. Most persons with HIV were not born with it. They acquired it in the course of their life. Now, the primary immunodeficiency are things like SCID, severe combined immunodeficiency disease. You were born with it. That is primary immunodeficiency. So anybody with primary immunodeficiency, avoid life attenuated vaccine first. The second thing is that you don't give this thing in pregnancy. A pregnant woman should avoid life attenuated vaccine. The third one is this. You can give it in HIV, but on one condition. If the HIV patient has a CD4 count that is 200 and above, that patient is eligible to get life attenuated vaccine. But if the CD4 count of that HIV patient is less than 200, run away from life attenuated vaccine, except you want to cause problem for the patient. Now, if that is understood, the final thing is this: you have to know the name of these life attenuated vaccines. For example, you can get a clinical vignette now of a pregnant woman that came to the hospital, and they now ask you which of the following vaccines should be given to this patient. And in your answer choice, you're seeing 4 of them that are life attenuated, and you're seeing 1 that is killed. Now, you have to know the only way you can pick out that right answer in that clinical vignette is if you can marry the name and say, oh, varicella is a life attenuated vaccine. The like of adenovirus is a life attenuated vaccine. Now, the question is, how on earth are you going to remember all this? So there's definitely a mnemonic we use. There's a mnemonic we use. If you have something easier, you can always share. Now, the mnemonic FA uses, attention teacher, please vaccinate small, beautiful young infants with MMR routinely. Yeah, that will make sense for some people, but man, if you're under exam condition, you're going to forget that thing straight up because you have a lot of things in your head. So what I do is this. This is the mnemonic I use. I use my, it was supposed to be like this. My boy rats vaccine. This is how it's supposed to be, but we made some alterations to it. We made some alterations to it. So this is how it is. You need to pay close attention. So this is mine, normal mine. The boy, we offered it instead of a Y, we replace it with an I. Then this is the rats. Then look at the vaccine, how I spelled it. It's a capital V and everything small letter, telling you that this is the only thing that is important in the mnemonic. Now your M is your MMR. This is the MMR. MMR is definitely a live attenuated vaccine, MMR. Your Y is the yellow fever. So yellow fever is the next. This is the BCG. That is the B. The O is the oral polio. Oral polio. This is the one you call the Sabin. That's another name for it. The I is the intranasal influenza. The R is definitely your rotavirus. The A is adenovirus. The T is definitely the oral typhoid. The S is the smallpox. And the V is varicella. You will have to know these names like this. If you have an easier mnemonic, that's beautiful. But you have to know these names. MMRO, that's my boy rat vaccine. MMRO, yellow fever, BCG, oral polio, intranasal influenza, rotavirus, adenovirus, oral typhoid, smallpox, varicella. You have to have it at your fingertip because it is a very high yield concept. And by the time you mix it up, you fail the question. And it is so painful that you fail the question because you couldn't place it as either life attenuated or you couldn't place it as maybe a killed vaccine. If that is definitely settled, we look at the next one, which is the killed vaccine. So this one is that the vaccine, the organism is definitely dead. It is dead or completely inactivated. Now, this one has certain advantage, but it also has certain disadvantage. Now, the advantage of this one is that you can use it in almost everybody. You can give it to a pregnant woman, you can give it to somebody that has HIV and the rest. But now the disadvantage is this. It doesn't cause a strong immune response. The immune response it causes is very weak, very, very weak compared to the life attenuated. Now, if that is the case, what are the vaccines that is under the killed or inactivated? That is where we have four important vaccines. No, five important vaccines, basically. That's why we have the hepatitis A, the typhoid, intramuscular, the rabies, the intramuscular influenza, and the intramuscular polio. Now, see what I want you to observe. Most of your oral vaccines are live attenuated. Now, any vaccine, most of the vaccines you give intramuscularly are the killed vaccines. For example, look at influenza. The influenza you give intranasally is the live, but the one you give in the muzzle intramuscularly is the killed. Look at polio. The Salbin is the oral polio, the one you give by mouth. Now look at the sac, the killed one, the one you give intramuscularly. Look at your typhoid. The one you give by mouth, oral typhoid, is definitely the life attenuated. Look at the one you give intramuscularly. It's definitely the killed vaccine. That is what you need to know. So a trip is the mnemonic, and that one makes sense. Hepatitis A is for the A. The T there is for typhoid, but know that it has to be intramuscular because you can get oral Typhoid, intramuscular typhoid. Intramusculars are basically killed. Now, if that is settled, I want to talk about the toxoid vaccines first. Before I will now go and look at the recombinant. That's what we're going to end for the vaccines. I'm not going to talk about the mRNA. That is the COVID vaccines, and I've told you why. Now, if you look at the toxoid vaccine is very unique in the sense that for other type of vaccines we're talking about, you definitely have the vaccine targeted against the organism. But in your toxoid vaccine, the vaccine has little or no business against the organism. Rather, the vaccine is targeted against a product of the organism. For example, if you look at Clostridium tetani, the one you call tetanus in Nigeria, now the nomenclature have changed. It's tetany. That's what they call it now. Well, I know people from this part of the world will call it tetanus. Whichever way you want to call it, we understand. Now, you see, that particular organism, it is not the organism that is causing the problem. It is the tetanus plasmin that the organism is producing that is causing the problem. Now, that organism does not move. For example, if you have a nail prick on your foot, Clostridium tetani will remain where you have that nail prick, inside that deep wound. But you see, from that place, it will be producing toxins. It is the toxin that will circulate and go to your neuronal bodies and cause the tetanus. So in that case, what they are targeting is not the organism. What they are targeting is the toxin that is causing the problem. That is what the toxoid vaccine does. Basically, its primary target is not to the bacteria. Its primary target is to the toxin produced by the bacteria. And the two you have to know is definitely the Clostridium tetani. That is the Clostridium toxoid vaccine. Then the other one you need to know is the Corynebacteria diphtheria. The vaccine, the toxoid vaccine against it. You would have heard of the DPT. The DPT is a combination of your diphtheria, your tetanus, and your acellular pertussis. So that is a classic toxoid vaccine. Now, the biggest thing they want you to know for toxoid vaccine is that the target is not the causative organism, but the product of the organism. The drawback to toxoid vaccine is that they don't last a long time. So you will need to keep supplementing with booster doses. Now, the final thing we're going to look at is the recombinant vaccines. Now, see, what I do when I look at the polysaccharide, recombinant, and conjugate vaccine is this. I know what my life attenuated vaccines are. I know what my killed vaccines are. I know what my toxoid vaccines are and the members under them. Any vaccine that does not fall into these three categories is definitely under the recombinant, polysaccharide, and conjugate. I don't even bother memorizing them. This is just how I keep it straight. If I ask myself, is this under the life attenuated? If the answer is no, is it under the killed? If the answer is no, is it a toxoid? Then it definitely belongs to the recombinant group. Now, the recombinant, the polysaccharide, the conjugate vaccine group are those groups that does not fall into any of the categories I have mentioned. Now, what you do is that you just pick an antigen from that particular organism that you have interest in. You use that antigen to now formulate a vaccine that is capable of stimulating the body to produce antibody against the organism. That is how the recombinant and conjugate vaccine comes in. For example, take pneumococcal. Pneumococcal has a polysaccharide capsule that is a covering. Now, when you want to produce pneumococcal vaccine, you pick up that polysaccharide capsule, which is just an antigen, and then You formulate it in the vaccine and inject into the person. Once the person's immune cell senses that foreign antigen, they develop immunoglobulins against it. And that can definitely help in future times when the person gets infection with pneumococcal bacteria. That is where the recombinant comes in. But now, see the most important thing they want you to know. They want you to understand that there can be different types under this family of vaccines. You can have those ones that are plain vaccines, meaning they just have the polysaccharide capsules, and you can have the ones that are conjugated. Now, the important things they want you to know is the ones that are plain will definitely elicit only the humoral immune response because they don't have a peptide attached to them. They just have plain polysaccharide. Remember what I told you, that anything that does not have a peptide attached to it is not going to be capable of eliciting a T cell response. It's not going to be capable of eliciting a T cell response. It's just going to drive humoral immune response, which is going to be a weak type of immune response. But when you now conjugate it with a peptide, of course, you're not going to drive a T cell mediated immune response. And when you drive a T cell mediated immune response, automatically you're going to produce a stronger immunity. Now, that is the concept of the conjugated and non-conjugated. For example, your pneumococcal vaccine, the 23 variant, is an unconjugated vaccine. It's just a plain polysaccharide capsule. But now, your pneumococcal vaccine, the 13, 15, 20 variant, are conjugated. So those ones are going to produce a stronger immune response than your 23. This is what they want you to know. So this is where I will definitely want to draw the curtain for today's class. So as our policy is, I will definitely have to unmute so that I can listen to your queries, your complaints, and we see a way we can sort it out quickly before we run. So please, if you have a question that we need to